I'm Dr. Suraj Kappa, a Mayo Clinic cardiologist specializing in heart rhythm disorders. Today, I'm going to talk about cardiac ablation for treatment of ventricular tachycardia. Another mainstay of therapy is something called ablation. What is ablation? So this is a procedure that is invasive, where we essentially put IV lines in the area of the veins or arteries that allows us to get access to the heart. And we put wires up to the heart in order to both map and determine where the arrhythmias are coming from. If we can determine where they're coming from, we can apply different types of energy sources, such as radiofrequency energy or heat energy, or cryo or cold energy, to essentially destroy the cells that are acting up. Now, you might ask me, why are these cells acting up, and isn't it bad to destroy heart cells? The truth of the matter is that these cells are not really necessarily contributing in any significant way to your heart beating normally. They just act up on occasion to make your heart beat abnormally. So the act of quote-unquote destroying these cells is not going to necessarily make your heart function any worse or make you more prone to heart failure or other types of diseases. Now let's talk a little bit about how this is done. Now when we put IV lines in to get access to the heart and get the catheters up there, we watch underneath a large X-ray type camera called fluoroscopy in order to identify whether or not those catheters are in position inside the heart, and in order to identify how they are relative to where we figure out the arrhythmias arising from. In this example here, you see a number of different catheters lying in the heart that are visible on the X-ray camera, and you see the heart actively beating. The one catheter that is actually going up here is actually the ablation catheter that is used to deliver the energy needed to result in termination of the arrhythmia. However, X-rays are not the only thing we use. We also use something called intracardiac echocardiography, which actually allows us to visualize structures inside the heart like we would with a typical ultrasound, in addition to the catheter itself, like we see here, where you visibly see an ablation catheter near the pulmonic valve actually applying energy to an area of tissue that's responsible for arrhythmia. While we're doing all that, we're not just looking for physically where is the catheter, but we're also obtaining signals. These signals are used to both deliver stimulatory energy, as well as to sense how the cells are activating relative to the extra beats or ventricular tachycardia you might be having. In this example, we show that we're actually stimulating the heart to see whether or not when we're stimulating a specific spot, the beats look similar to the extra beats that the patient is having. And this allows us to localize exactly where we might need to ablate. The last component of this is we use a complex thing called an electroanatomic mapping system. Now, this has been developed over the course of decades by several investigators. And a lot of the technology that's actually underlies this has been created here at Mayo Clinic. And what it entails is actually obtaining a series of points in order to hone in like a bullseye, like this red area right here, on exactly where the arrhythmia is arising from. And this allows us to figure out, in this huge three-dimensional framework, exactly where we need to focus and target. Now, this can be both done in both the normal heart, but as I said before, there are also sometimes abnormal hearts. And in the abnormal heart, it's a little bit more complicated. It might not just be a single spot, but a region of tissue that could potentially lead to an arrhythmia. In this example, we show an infarcted heart, where somebody's had a heart attack, and because of that, they have a region of scar, which we see here. This region of scar has signals getting into it, but because it's scarred, what happens is this conduction through it is relatively slow. And because it's relatively slow, in certain special situations, it can result in a rhythm called ventricular tachycardia. This ventricular tachycardia propagates through the scar and essentially creates a short circuit that travels around continuously, such that the ventricles take over and go off on their own. In the Electrophysiology Lab, We use that 3D electroanatomic mapping system I discussed before to create a three-dimensional shell of the heart and understand where the substrate is that might be leading to these ventricular arrhythmias. As in this example, where we made a map of the left ventricle and showed in these extensive red areas that these are the areas that are essentially scar or abnormal cells that are not necessarily contributing to appropriate functioning of the heart, but are actually potentially leading to ventricular arrhythmias. And thus, we have a region through which we might provide lesions or heat energy to destroy the abnormal cells that are acting up and causing the abnormal arrhythmia, but are not necessarily helping the heart act normally. So how do we think about this? In the abnormal heart, we first look for reversible causes. And these might include anything from repeat coronary disease to drugs you might be on to electrolytes. But then we have to figure out, all right, you're coming to me with ventricular tachycardia. How quickly do we need to treat you? If the events are intermittent or rare, and you already have a defibrillator or another treatment mechanism in place, there might not be a need for immediate hospitalization. But if you're having so many events that you're either getting repeated shocks from them or having other issues from them, you might need immediate control that might require hospitalization. And how do we get it under control? Most centers have the capacity for most of the ways we treat them acutely, such as applying block to what we call the sympathetic chain, or this region that can apply adrenaline energy to the heart that can sometimes stimulate these abnormal rhythms, providing drugs called antiarrhythmic drugs, as we talked about before, for either acute control or chronic control, giving general anesthesia, or even treating the underlying cause if we can identify one. But sometimes you might require more advanced care. And this is where sometimes individuals like myself or like the Mayo Clinic can help. We can provide hemodynamic support using specialized procedures such as ventricular assist devices. You can provide VT ablation, these complex procedures meant to eliminate the short circuits contributing to the arrhythmia. And sometimes more advanced options such as transplant or something such as the total artificial heart or sympathectomy by permanently eliminating the adrenaline drive to the heart. So how do we pick between all these options and decide what is the right one for us? This is oftentimes where we lack the definitive guidelines to decide, and we need to go by a team-based approach, where the patient is as important as the provider. And we need to talk about the options and discuss what makes the most sense based on the risks and based on the likelihood of success. In patients with abnormal rhythms in a structurally normal heart coming from specific regions of the heart, such as the outflow tracts, ablation might have an upwards of 90% likelihood of long-term success and cure, whereas medications might have at best a 40 to 50% likelihood of efficacy. But in cases such as the structurally abnormal heart, those numbers become closer together, where medications might have a similar likelihood of working of 40 to 50%, but ablation might be more like 50 to 70%, depending on the situation. So we have to closely discuss what the options are, and in your specific case, what might work best. When we think about ventricular arrhythmias as a result, we need to think of them in a systematic way. Are there other causes? Are they dangerous? And based on that, do we need other devices such as defibrillators as a safety net to protect from sudden death? And do we need to treat them, whether with medications or with more invasive therapies such as cardiac ablation? Today we've discussed ventricular arrhythmias in some detail. For more information, please contact us at the Mayo Clinic.